Welcome to episode 9 of the ARME Radio podcast, the show where we aim to offer accessible education to healthcare and fitness professionals alike and to bridge academic research to the clinical setting. In today's episode, Dr. Lora Giangregorio joins the team. Lora is a professor at the University of Waterloo and is a Schlegel Research Chair in Mobility and Aging. The aim of her research team is to reduce the burden of osteoporotic fractures using medical imaging technologies to explore bone and muscle responses to activity or neurological impairment and evaluate new methods for image analysis. They conduct epidemiologic studies to inform fracture risk assessment algorithms and clinical trials to investigate the effects of exercise interventions for reducing fracture risk in high-risk individuals. Her research team has worked with Osteoporosis Canada to develop Bone Fit, a 2-day workshop for physiotherapists and kinesiologists on appropriate assessment and exercise prescription for individuals with osteoporosis. They've also led the development of the 2 Fit to Fracture exercise and physical activity recommendations for individuals with osteoporosis. For more information and resources, visit us at www.thearme.ca, and we hope you enjoy today's episode. Yeah.
Okay, so you probably, I'm trying to remember. The other course I teach is called Kin 414, and the first 2 years I taught it as a Kin 471, which is kind of like a placeholder. And it's called Cases in Clinical Exercise Physiology. So I don't think
I heard about that. It came on like just after I left, and I was kind of like, darn.
Yeah, it's really fun. It's really fun to teach anyway. I don't know if people can like it, but I like it. But yeah, it's basically the idea was that, most people that you see, they don't just have one condition often. Like, people are complicated, right? You get, and it's kind of, it seems simplistic to say, okay, this is how you do exercise with osteoporosis, and this is how you do it with cancer, and this is how you do it with, when really people present with multiple things often, right? So the idea was to give people a case that has multiple things going on and think about how to prioritize your assessment and your prescription based on the person rather than based on the impairments that they have. Not based on diseases.
Not labeling them, right?
Yeah. So they do a lot of learning across different chronic conditions, and then the sort of capstone activity, I don't know if you want to call it that, but basically we have an event called Connection where we recruit 40 or so people from the community who have either osteoporosis or osteoarthritis, and each student gets paired with someone and they have to do like an assessment and teach them some exercises. So it forces people to do a little real world stuff, which, so we have like a big event and they all come and we do it, and it's really fun. Cool. It's definitely, I just figured, like, let's up our game. Like, we can do some fun things with our program, and it's a lot of work for me to run. I'm not going to lie. Like, it's a lot because I have to organize a huge event with all these people coming, and you pair students, and we have to do practical exams to make sure students are ready. So we actually have like a bell ringer where they come in and they have to do assessments, and we evaluate them evaluate them teaching squats and all that stuff. Which is, kind of stressful for the students, but so it's a lot of work, but it's a lot of fun to do. So
way harder than just setting up a Scantron, right?
Well, so multiple choice exams, have their place, but when you're in 4th year, like, you really need to be evaluated on your ability to think rather than make choices.
Absolutely.
I'm in my basement. We have this like room where I can close the door because my family's upstairs and my boys are really loud. And you'll probably still hear them, but I just thought, like, this is the quietest place in my house. So that's why I'm in this like weird dark basement.
That's fair.
So sorry.
You're totally fine.
Yeah. I'm in the same spot here. I'm just in my hockey cave in the basement. So like,
at least it has a good name. I don't have a good name.
Yeah, there you go.
So today we are lucky to be joined by Dr. Lora Giangregorio from the University of Waterloo. Thank you very much for joining us today.
You're welcome. Thanks for having me.
So first things first, for the people who don't know about you, can you tell us a little bit about kind of your story and how you got involved in academia, where you are now, and what your research interests are?
Well, that's a good question. So there's a long answer and a short answer. Let's just say that I started my undergrad in Kin thinking that, you know, I would be a physio and then I would volunteer in a physio clinic and be like, that's not my thing. And I kind of volunteered in different capacities, and eventually ended up doing a 4th-year thesis and thought, I like being holed up in the library and reading and thinking about things. I'm a little bit of a weirdo that way. So, because you used to have to go to the library to read articles. You had to actually physically go there. You don't anymore.
No.
But anyway, so I ended up, I was encouraged to go to grad school, and I did that. And it really was just, you know, people would say, hey, why don't you do a master's? I'm like, that sounds like fun. And then I ended up in a PhD program, and then somehow I ended up interviewing at Waterloo, which was funny because I didn't expect to get the job. I was just like, okay, well, I'll do the interview because it'll be good experience. And then I got the job. I'm like, okay, this is awesome, but a little scary, to be honest. But it was great. And, you know, I think the biggest thing is having mentors, and not just sort of when you're a student, but also, you know, when you're in your professional life, and they don't necessarily have to be more senior than you, or, you know, these sage people who have all this life experience. It could just be someone who knows things that are different than what you know. And that's how you learn, right? So if you want to learn about, like, I wanted to learn about how to properly run clinical trials. And so I sought out some mentors and worked towards building some skills in that area. And I did that as in my professional career, like when I was early career. And it was really helpful because it helped sort of chart the path for some of the research that I ended up doing. So I think probably the biggest thing that helped me in my path was having really good mentors. And yeah, so I ended up as a faculty member at Waterloo, and I've been there ever since.
That's awesome. It's always fun to kind of see that journey. And you did your PhD at McMaster, correct?
Yeah. So I did my undergraduate in kinesiology at Waterloo. And then I went to McMaster to do a master's and ended up in the PhD program. So they have a fast track program. So I just ended up in the PhD program. So I never actually finished the master's. And I worked with Neil McCartney, who was very well known for his work in cardiac rehab. And so I actually went to McMaster to do a master's in cardiac rehab, and was distracted by the fact that he got a grant to do this big project in spinal cord rehab, looking at bone and muscle. And he's like, well, so basically I was in the master's program, and he said, well, I got this grant, but it's a PhD level project. So do you want to change your topic and enter the PhD program and do this project instead? And so that's how I ended up learning about bone and being interested in bone, because of the fact that he had this grant and he needed someone to work on it. And then I ended up meeting some other mentors that I worked with, Alexander Papuano and Ricadaci, who are also at McMaster. So I did some side work with them, and that's how I developed some more expertise in osteoporosis.
Yeah, that's kind of how speaking of osteoporosis, that's how I kind of stumbled into your work. Is one of my favorite topics is sarcopenia and healthy aging and frailty. And the reality is that there's such an intercollaboration, interconnectivity with osteoporosis. We know that things like osteosarcopenia are becoming a more well understood idea. But for those of us who don't really have a full appreciation of osteoporosis, can you dive into a little bit more about what osteoporosis is? And even maybe just introducing osteopenia as well, and kind of that whole spectrum of why it is and what it is and why it matters.
Yeah, so osteoporosis is a bone disease, and it's when our bones become weaker. So you're more likely to have what's called a fragility fracture, a fracture that occurs during an event that wouldn't normally cause a fracture. So examples would be, if you're bending to tie your shoes and you fracture a vertebrae, right? You develop your peak bone mass, and then you kind of sit there, between the ages of, say, like 20 and 40, and you start to lose bone mass with age. And then women, when they go through menopause, sometimes have accelerated bone loss during that period. So then they'll have age-related bone loss, and then they'll have sort of postmenopausal bone loss. And depending on how much bone you started with and how much bone you lose with age or with menopause or with other things. So there's other factors that can influence bone loss. Like, for example, if you're on glucocorticoid medications for longer than 3 months, if you have certain medical conditions like rheumatoid arthritis or diabetes, other things can also cause bone loss. So if you, for example, don't have a really high peak bone mass, then with age-related loss, you can lose bone sooner. Or with postmenopausal bone, you'll not sooner, but you'll have be at risk, I guess, sooner. And so people will develop osteoporosis when their bone mass is 2.5 standard deviations below normal. So when your when you lose enough bone that you're that low, then that's when it's called osteoporosis. Now, the way it's actually assessed, or risk assessment is done, is not risk of osteoporosis, but risk of fracture. So they use these special risk prediction tools to determine who is at risk of fracture. So the actual term osteopenia is not used as much, or it's not encouraged, because people who, it used to be that you say, okay, well, people who are osteopenia have lost some bone, but they haven't lost enough to be called osteoporosis, right? And then osteoporosis is, like I said, that 2.5 standard deviations benchmark. And the problem is that lots of people with osteopenia will have fractures, and there are people who have osteoporosis who won't have fractures. So there are now risk assessment tools that help us identify who's at risk of fracture a little bit better. So one of them is called FRAX, and you can actually Google it. So if you Google FRAX, you can Google the risk assessment tool. And if you have a bone density scan, you can fill it out and determine what your risk of fracture is. If you don't have a bone density scan, you can still do an assessment without that. And they do it by country. So you have country specific normative data, which is pretty cool. And they look at a number of risk factors. So things like what your BMI is, if you have a family history of hip fracture, if you have rheumatoid arthritis, if you have high alcohol intake, if you have sources of secondary osteoporosis, and then what your bone density is. And all of these things are used to determine what's your risk of fracture in the next 10 years. So fracture risk assessment and the evaluation of osteoporosis has evolved to not just look at what your bone density is, but also what risk factors you have.
That is extremely interesting. I actually have the FRAX tool pulled up on my other screen, funny enough, because I was looking at some stuff earlier today about it as well. Yeah. But that's, I don't know about you, Dave, but that osteopenia, osteoporosis line is something that I was not familiar with, because we are taught, or at least I've been taught, that there is that distinct cutoff. But understanding that there is such a sliding scale of importance and all the other multifactorial aspects towards fragility fractures is really important. Like, Dave, I'm not sure if you've seen that, if I'm the only one that's lost here.
Yeah, no, like I feel like most things are going to be on a spectrum, right? And I kind of just want to branch off into another question that I had based off your little explanation there, was how we're kind of taught to deal with some of these individuals clinically, whether it is osteopenia, osteoporosis, is to be very, very careful with a lot of them. And sometimes I wonder if maybe we're underloading some of these individuals. What are your thoughts on some of the best ways to try to intervene or try to prevent in some of the elderly population when it comes to resistance training or other forms of exercise for them? Should we be as careful as we're taught?
Okay, so let's differentiate between elderly and osteoporosis, because there are people who have osteoporosis who are not elderly, and so we don't want to. So there are people, who we have this vision in our heads of osteoporosis being this little old lady with a cane who's all bent over, and there are lots of people with osteoporosis who you wouldn't know to look at them. So, and you can develop osteoporosis even at a young age. So when I was in grad school. I was in grad school with this girl, and both of us needed to learn how to do DEXA scans. And so we had to have scans done on each other. And I was looking at her scan and I was like, you have osteoporosis. And we looked at it, and her bone density was really, really, really low. And it made, in hindsight, it made sense, because she had recently, like in the last year, fallen off her bike and fractured her elbow. And it was like a really fluke accident. And so it's just something I like to encourage people to think about, is that, you can lose bone mass at younger ages, especially if you either don't have high peak bone mass or if you have certain risk factors. So women, for example, who have a hysterectomy or early menopause, either because of cancer or other scenarios, they will lose bone earlier, right? And so they can be at risk earlier in life. So stepping that aside, if you're thinking about sort of exercise prescription, your question is are we underloading people? It's a very topical question. So historically, people who have osteoporosis, especially people who have severe osteoporosis, are told, don't bend and don't lift and, don't twist. And there's sort of this fear-invoking language. And we did some work a few years ago around, how should we provide guidance to people with osteoporosis. And the consensus was that you should try to avoid that kind of language. So that kind of language creates fear, right? And the people don't want to do anything. And it's not that people can't lift, it's often the biomechanics of how they lift we have to think first about how we speak to people and not create fear. And then the second thing is around exercise and what you can prescribe. And unfortunately, there's not a lot of randomized trials where they randomize people to really heavy loading and then say, you know, do they fracture or not? And so a lot of the studies have been a bit, I guess, conservative with their loading regimens, or they would recruit healthy postmenopausal women, but they wouldn't necessarily target people who have really low bone mass. So, you know, you could say, what is the effect of exercise on bone in healthy postmenopausal women, but not in people who have low bone mass? And the third variable is that people with osteoporosis are often on medication that affects bone. So then they can't recruit them for the studies because they're on these medications. So it's quite difficult to study. And then then there's also the variable that exercise studies typically in the past have been small samples, not always the best study design, you know, lots of risk of bias. So then it makes it really difficult to interpret. So more recently, there's been a few studies that have sort of challenged that notion around, you know, we shouldn't be loading people. So the most, I guess, famous one is the Liftmore study, and they basically took a bunch of people with low bone mass, and they had them doing deadlifts and squats and, you know, overhead presses, and they saw some pretty impressive findings when it came to bone mineral density and physical functioning, and they did not have any adverse events in the trial that suggested that the training was dangerous. I think that's a really good way to challenge the paradigm, and it's risky, right? Because you don't know what's going to happen. So there's a couple things to take from that. It shows what the potential is. So it shows that, you know, you can incorporate resistance exercise in people with low bone mass, and there are ways to do it safely. And you can actually stimulate bone. Now, that's one study. It's been replicated in men by the same group. So what I'd like to see is other groups replicate it, because that's an important thing in science. You want to see replication, because if there are sources of bias, you want to, you know, if you have somebody else replicate it, then you're more confident that the results are real and not just something that happened in their lab, right? I'm not suggesting that's the case. I'm just saying that that's an important thing to do. So I would like to see them replicated, but I would say that it's very encouraging, and it makes it more easy for me to say, as a person who's writing guidelines, yeah, I would definitely recommend resistance training, and I would make sure that it's challenging. Mm-hmm. Now, there's a couple of caveats there. One is that the women in the first Liftmore study were, I would say, probably on the healthier end of the spectrum. You got to remember I don't know how often you do resistance training, but there's certain people who just won't do it, right? They will not do it. So the people in that study have opted in to a heavy resistance training program, and they're not afraid of it. And their average age was 65. That's actually pretty young for older adults, right? Like it's the border between middle-aged and older adults, right? So, you know, I think you're looking at like a fairly healthy group of postmenopausal women who have low bone mass. Where I get a little bit more nervous is when we start talking about people who have other physical impairments, who have vertebral fractures, who, you know, maybe don't have the body awareness, have balance issues. So that study, for example, if you look at the exclusion criteria, they excluded a lot of people who have, you know, MSK issues and stuff like that. So if you try to translate that to every older adult, it may be quite challenging. But it doesn't mean you can't do it. So it just means you may have to modify your approach to resistance training. So you may need to focus on alignment a little bit more than on intensity, and eventually progress them. And they may never get to high intensity resistance training, but they can at least progress to maybe moderate, or, you know, doing a modified range of motion or something like that. So my personal opinion is that anyone can do resistance training, but you need to find where the person is at and progress them accordingly. And I can say from experience that, you know, even with careful attention to form and alignment and all that stuff, people can get injured. So we just did a trial, and we were trying to look at a method for disseminating balance and strength training in communities, right? Because the reality is most people can't afford a personal trainer, and they don't want to go to a gym, and, you know, so they might go to a local Y, and or they might go, say, to the exercise class in the retirement home. And so can we actually deliver balance and strength training in those types of environments for this group. So we did a study and we had people who were pre-frail. So these are the people with multiple health conditions, with mobility issues, etc. And we had one woman and she was 80, she had a history of hip fracture. So this is like high risk person. She was very fit, but just stumbled a bit on a step up and fell. And, the person who was supervising caught her, but didn't quite catch her fast enough. And she fractured part of her pelvis. So it's even with, supervision, there is that risk. So I guess this is a really long answer to your short question.
That's okay.
I have a tendency to do that. But basically, I guess what I'm saying is you have to meet people where they're at, and you also have to make sure that you put things in place to reduce the risks and help people understand that there is a risk, but hopefully the benefits outweigh those risks.
For sure. That was like a perfect scientific answer. And I really like the perspective of just, we have a couple of RCTs, but we need more, because I find oftentimes in the clinical setting, a lot of clinicians see that one or those two RCTs and then they run with it, right? Which I think sometimes we have to be a little bit more patient on that. Another thing that you mentioned, because we love to talk about this all the time, is just the importance of words and not having, because people come in with negative perceptions. We know that expectation for a lot of people will alter the effects of said intervention. So if they're coming in with really negative expectations and fears on, say, for example, resistance training, we're going to have a lot more barriers to deal with, right? And you said that you have to probably meet them halfway or somewhere.
Meet them where they're at. So if they're not willing to come into a gym, how can you get them to do it at home? Like, there is going to be a large proportion of the population that are not willing to go into a gym and do deadlifts. And so how can you get them doing activities in their home that, will provide a similar stimulus? And I think the biggest challenge is to get people to work at the intensity that you want them to. So it's one thing to teach someone an exercise. And I think this is something that's dogged the physio community, is the whole 3 sets here, do this exercise 3 sets of 10 and off you go. But then they're maybe not spending enough time. And it's not the physio's fault, it's the model of delivery. They don't have the time. They're not given time to spend with people. But the idea of, have they actually found the intensity that the person needs to work at? And some people actually need to be coached to push it just a little bit more, right? And I think, Stu Phillips' lab has really pushed this idea of, it's not so much, the amount of weight you lift, but are you actually, doing the work up to a point where you're getting to fatigue, and that's what's stimulating further growth and further change, right? So some people can do lower weight and higher repetitions as long as they're getting to the point where they're like 1 or 2 reps in reserve, right?
Right.
Yeah.
That leads me to just a follow-up question on there. Sorry for taking over here, Ben.
Go for it. But this is great.
Yeah. So in those cases of individuals who do have those maybe negative expectations or other barriers, obviously there's other forms of exercise that we can do, like you said, just like modifying to their level. What are some other alternative interventions or forms of management that we could also focus on for someone who is like, I am not doing any exercise yet, I'm not ready for it yet?
I think you really have to listen to what the person wants, right? So, you listening is sometimes more important than telling, because people, if they have decided in their head they're not going to do something, you can't convince them to do it, right? We have this whole confirmation bias thing. I'm the worst, right? I'll go to a physio and they'll be like, you need to do clamshells. I'm like, I'm not doing clamshells, right? Like,
I wouldn't either, actually. So
no.
On the record, we want it on the record for no clamshells.
Yeah, but maybe they're, they're good for some people, but in my head, I don't like them and I won't do them. And maybe they'd be good for me, but I just don't like them. So you can tell me all the evidence you want, and I'm going to tell you I'm not going to do them. So, and I try to think of that as I'm working with people that, they're human and they have, their own ideas of what they want to get out of this experience with you. So listening to what they want and then trying to connect the activities that you're suggesting to the goals that they have or the things that they're willing to do. So I'll give you an example. I was doing a study and I had a woman who had, she was overweight, she had knee osteoarthritis, she had spinal stenosis and osteoporosis. So she's a bit more complicated. So she wouldn't have been eligible for the Lift More trial, right? So that's a good example where we've got someone here who she can do progressive resistance training, but I wouldn't start her with high intensity deadlifts and squats immediately. She had a really unstable knee, just had a joint replacement on the other knee, right? So her one knee was, she had knee osteoarthritis too. Did I mention that? That's also the other thing. So I just had one joint replacement the year before and was waiting for her other one. And so one knee was really unstable and caused her a lot of pain. And she also had a lot of back pain from the spinal stenosis. So I'm chatting with her about her goals and about how she wanted her knee to be less painful and all that sort of thing. And so I started chatting with her about squats, and I showed her what I wanted to do. And I said, it'll help it be less painful for you to get in and out of a chair, to get in and out of a tub or whatever. And she liked the idea of that, but she's like, that's going to hurt my knee. I'm not doing it. So she had a notion in her head that she wasn't doing this thing because it's going to hurt her knee. So we could probably try some other options. And I said, some people have found, so I said, what is it that bothers you? So she explained that, when I get down like that, when I bend my knees, it really hurts. I'm like, I can give you some other options. And so I had a couple. So first of all is giving a few options. The second was some people have found, so I'm not telling her what to do. I'm just saying some people have found when I use this band and, around a person's knee, it doesn't hurt as much. And also I said, the other option I can give you is what's called a partial one. So she liked the idea of doing something different. So all of a sudden I've changed the exercise now. And I just said, we're going to do a partial squat. So I put the band around, got her to do the partial squat without the band first. And then I gave her the band. She's like, oh, that makes it feel better. Because I was helping her, bring her knees out, which is essentially what you need to do to squat anyway, but it was giving her that cue to do that. And so by sort of changing it into a different exercise, mentally I had, kind of got her to consider it, where she had just said, whereas if she just said, I'm not doing that, and I just said, okay, we won't do it, we're going to go do seated leg lifts, she probably would have been willing to do that, but it wouldn't be as effective. So it's thinking about really kind of asking, what is it that bothers you, and providing options that also align with kind of what your therapeutic goals are.
Yeah, I mean, that ties in really nicely when we look at a lot of the research in pain, and we see how predictive processing and just people's preconceived notions play such an important factor, right? And you make a small adjustment and now it changes the context of the entire exercise, right? It's amazing what a band can do. It's not a squat anymore, right? It's that less threatening movement.
By the way, within 10 weeks, coming twice a week, she was doing not quite full squats, but more than partial without the band and a 20-pound kettlebell.
That is awesome. That is genuinely...
And I told her, I said, you are strong, and I'm confident that you could do this with a 20-pound kettlebell within a few weeks if you want, if you're interested in working towards that, right? So I kind of gave her a goal to work towards, and then it was like, now it's a competition. She's like, I gotta do it. So, and she did it, and she did 3 sets of 10. Like, she could have done a 40-pound kettlebell. She was strong. She just didn't believe in her strength, right? So it was sort of having her kind of get, like you said, she had this preconceived notion that that's going to hurt, and it did hurt, but can we work around that and find a way to make it less painful?
Yeah, I think that's the goal that we all hope to work with, especially when we're trying to encourage resistance training in this context, right? Now, there's one thing that you mentioned before, and I really want to touch on it because I'm very interested about it, and I've read a bunch, but I'm still, a little bit in the weeds on it, is when we're working with people who have a known vertebral fracture. So they've already had, whether it's an osteoporotic or not, a vertebral fracture. How much are we able to push that person through exercise in general? Is there limitations to it? Do we have enough research to make any conclusions on how we can tackle this? Or are we still early on kind of investigating this concept?
So I answer all those questions. So the first is, I don't know how much we can push them. Is there a limit? I'm not sure, but probably. Probably, because there are limits to the amount of bone loads that bones can withstand, especially when they're weak. And do we have enough research? No. So we did a Cochrane review looking at the effects of exercise on health outcomes in people with vertebral fractures. And there's very little fracture data. All the studies are quite small with the exception of 1 or 2. Most of the study, and interestingly, most of the studies don't really show that promising findings, and a lot of that is because some of the interventions are not super intense, and then also there's a couple of reasons. So there were some promising findings in the physical function component. Like it seems to improve functional mobility, like timed up and go type thing. But even when you look at the baseline scores, they're all quite high. So timed up and go tends to have ceiling effects in community dwelling people. So we might need to use tests that are a bit more challenging to tease out what the effects are. I do think we need to find a happy medium between an exercise intervention that's a bit more challenging, but also getting people to adhere to it and not scaring them away. Because I do think, so I worked with a PhD student, an international PhD student. She did a study in her country and they saw some really promising effects on mobility outcomes with exercise. So that work actually, I think, she's either just published it or it's in the process of being written up. But I think one of the big challenges is people with vertebral fractures, or even that group, is quite heterogeneous. So some of them have quite a bit of pain when they have the vertebral fracture, and it's pain that's really difficult to manage. And then some of them end up with chronic pain, which can then create issues around fear and that sort of thing. So I think and I do think there's a significant risk there. Like I said, we had a woman in our study, she was high risk and she had a fracture. And mind you, there was also a fracture in the group that hadn't started the exercise intervention as well. And she also had a pelvic fracture. So we were dealing with a high risk group. But this is a group that, once you have a vertebral fracture or a hip fracture, you tend to be at much higher risk for having fractures in the future. So one of our studies of exercise in women with vertebral fractures, we had a woman who fractured a vertebra while bending to tie her shoes. So this is a high risk group. So yes, if you make this person do deadlifts, they can fracture their spine. And I know that there are studies like the Liftmore trial that show that you can do it safely in people with low bone mass, but I still worry. And even in that trial, there was it was an interview, I can't remember with what newspaper, where the lead of the Liftmore trial was being interviewed. And she said, one woman picked up, not in the trial, but afterwards, because she's still running the program in her clinic. She said, a woman came into the gym and picked up a weight that wasn't intended for her, and she fractured a vertebra, right? So it can happen. So this is not a group that, just because we have a trial saying everybody should be doing high intensity strength training, doesn't mean that what I worry about is that's a really supervised environment. And if you start doing it in every gym with every person who walks in who has osteoporosis, I think unless you are very careful, Belinda Beck's group is a really nice model of carefully progressing people over time. And they start people with just alignment, right? So they just look at, how do you do the deadlifts movement safely without any weight at all? And then you have to very carefully progress that. And for some people, it's going to be too risky. Like if I had someone who had 5 vertebral fractures and severe hyperkyphosis and mobility issues, I'm not sure that I would start doing weighted deadlifts with them right away. You know what I mean? Because I'd be a little bit worried. I'd really have to make sure they had really good form and alignment before I start doing something like that. And I might maybe pick a modified one, like have a deadlift on blocks instead of them picking it up off the floor or something like that, right? So I might want to think about how can I modify it to reduce the risk. So what I do know is that we want to do some work in this area. So we've just recently done the process to develop new guidelines for Osteoporosis Canada. So there's going to be new osteoporosis guidelines coming out later this year. And it's going to look at diagnosis, treatment, exercise, and nutrition. So look for that. But in that process, we've reviewed a lot of literature, and there's not very much in people with vertebral fractures. So our next step is to have a master's student who's going to do some interviews with people with vertebral fractures and physios and other stakeholders who manage these patients, and say, what is it that you would want in a rehab program after having a fracture, and what are the things you want to know? And we're going to look at the domains of pain management, exercise, safe movement, like how to move safely, and nutrition. And we're going to try to use that information and the evidence that we review to try to develop a virtual, kind of a framework for delivering virtual education and rehab for people with vertebral fractures. Because the other thing is that sometimes they don't want to leave their house because they're in a lot of pain, and they don't have access to physio, or they live too far, or they don't have a physio in their community that specializes in osteoporosis. So we want to figure out, how can we develop some sort of program that people can access that will at least give them a starting point for where they should start? Because this is a group that, notoriously, there's been very little research on how to use exercise. But I would still use the same principles. So I would start with functional exercise, balance training as a starting point. And this is my approach to osteoporosis now, after going through the guidelines, is functional exercise and balance training as a starting point, because often that's how you get people in. I want to improve my function. I want to have less pain. I want to, so you work on those things, and then you integrate, as part of the functional training, progressive resistance training, right? So ultimately, I do think everyone with osteoporosis, including people with vertebral fracture, should be doing functional strength training, balance training, and some aerobic conditioning. But I think that, like, if I had to prioritize it, I would probably start them with like the functional training and balance, and then integrate the strength training. And I would say the same is true for people with vertebral fractures. You just might need to be a bit more cautious with your progressions. That's a really long answer to your current question, but hopefully I got there.
No, it's a challenging topic, and that's kind of based on, again, the handful of articles that I dove into. That's kind of what the trend is, exactly what you're saying, right? It's in its infancy in developing, looking at kind of more robust and larger clinical trials where we can actually assess what is safe. And like you said, it's a vulnerable demographic, right? And things can happen. I remember I was reading a study yesterday, I think, and it was 5 older adults with low bone mass had fractures in the control group. They weren't doing anything, just during that time period, they just had fractures. And so there's that risk is just there, right?
Yeah.
So I can fully appreciate the apprehension into just, without piloting things or just trying to augment that loading might be scary, right? And it is. Now,
I think people, I was just going to say, like, as with anyone, you have to start with alignment, right? And you have to start with, can they actually do the exercise with good form before you start loading them, right? And it may be that you have to spend a bit more time on form, especially in people who maybe, like one woman we had in our study, she had low bone mass, and it took me a couple of weeks to coach her to do a squat properly. She had a couple issues, like she had scoliosis, she had really long legs, she had, not very good body awareness. So it was trying to find the right cues that worked for her. And eventually, over time, with practice and with different cueing, and she really benefited from the high box squat, like having something to aim at. And so, we got it, but like I had to spend a bit more time on that before even loading her. And I that would be where I would be a bit more cautious, is like focusing on form before starting to load people. But it's not to say that you can't have people who have osteoporosis lifting weights, because I think they can. I think it's just a matter of doing it, making sure you're doing it safely.
Yeah, absolutely.
So you mentioned you have a student doing a little bit of qualitative research, correct?
Yeah.
Obviously, a lot of people don't really like to enter that realm, because I know the methods and stuff like that can be a little bit all over the place and confusing. But do you think that's an area where perhaps more research might be needed in a lot of these conditions or comorbid individuals, just so that we can have a better idea of their perspectives? Because I don't see a lot of it out there in a lot of conditions.
I do think it's important. I think, so I will say I'm not a qualitative researcher. I have dabbled in using some qualitative methods, but at a very superficial level. Like most of the stuff I do is a basic thematic analysis or a content analysis. I don't get into sort of, grounded theory and all that stuff. And it's not, I think it's super valuable. I just don't know how to do it. So, not well anyway.
I don't think a lot of people do, actually.
Yeah, I have a basic understanding of how it works. I often will consult colleagues that know what they're doing to make sure that what we're doing makes sense. But in any case, I think really the design you choose should be based on the research question. So if your research question is, you know, what is this person's perspective, then you have to ask their perspective. If the research question is this effective, then you have to do a randomized control trial. So a lot of the choice of study design is really around what the question is. It's not to say we should just do more qualitative research. It's like, well, what I think we need is multi-method research that is inclusive of patients and those that advocate for patients. So it's not just doing qualitative research, it's having the patient on your research team to help you know what is actually important to them, so that when you choose a research question, you choose a research design, you choose the outcomes, you do your intervention, it's informed by the patient, so that they, so for example, if you're designing an intervention, is it an intervention that patients would actually be willing to do? Are the outcomes that you're measuring, like to see if it's effective, are they the outcomes that are actually important to the patient? Because a lot of times, you know, it's actually funny, when we did the guidelines, the 2 Fit to Fracture guidelines in 2014, so we started that process a year or two before. And the process required that we define a list of outcomes. So we're going to look at the effects of exercise on this list of outcomes. And the researcher team made a list of outcomes, and it was like fractures and bone mineral density and falls and those sorts of things that people measure in trials, right? And then we did some qualitative interviews, and I'm just talking like a few with 4 people, with people who had osteoporosis. And, you know, one woman said to me, no, a fracture is important, but it's only important in the context of the fact that after a fracture, I cannot do my groceries because I can't lift them, and then I need someone to do them, and I feel like useless because I can't do the things I want to do. So what's actually important is me being able to do my groceries, and the fracture just impairs me to do that. So the outcome that was important to her was her physical function, not the fracture. So if we're going to be measuring something in a study, we should be measuring physical functioning because that's what's important, or quality of life if that's what's important to them. So I think, to answer your question, it's not that we just need a whole bunch more qualitative research. We need research that's informed by what patients think is important, and policymakers and physicians and all that other stuff, but also patients.
Yeah, that you mirrored. We had Dr. Tasha Stanton on recently, and she said pretty well the same thing. Just yeah. Get more, you know, third parties and stuff involved to get those perspectives, and that's awesome.
It's also important to not do it in a tokenistic way. And that's the thing that what concerns me about, so we have a lot of granting organizations that have focused on patient-oriented stuff and involving patients. And so everyone's got this thing now where they have to have a patient on their team, but it is often done in a very tokenistic way. And I think researchers need a bit more guidance and help in terms of how to actually do it well. And that is happening. So there are initiatives in place that are trying to move that agenda forward. And, you know, I've worked with some really good I've been really lucky to be able to work with Osteoporosis Canada, and then through them work with a number of really vocal patients who want to see better research. And so being able to work with them on studies and, you know, involve them and say, hey, how do you want to be involved? Do you want to be on the team? You want to be an author? You want to do that? Like, let's do it together. And, you know, it's funny, we had patients actually reading the transcripts, like looking at the data and saying like what they thought of it. And they had some really fascinating perspectives that I read it and I went, this is what I think. And they're like, well, what about this? I'm like, oh, I didn't even see it that way. Right. So it was really neat to have and they're very involved, but not everyone has that luxury. So I think it's just trying to do better wherever you can.
Yeah, and on that note, we won't take too much more of your time, and we want to thank you so much for joining us today. This was really, really informative, and really, really eye-opening, and just kind of reinforces, I think, for both Dave and I, and hopefully the other people, the kind of the next step forwards we need to all take and be more aware of. So for people who want to get more of your content, can they find you on social media anywhere? Can they find you? Where can they get more Dr. Lora Giangregorio content for
them? So I'm on Twitter. I am on Instagram. I'm really not good at it. I don't think in pictures. So I don't take a lot of pictures, so other than of my kids doing stupidness. So I am on Instagram, although I don't post very often, but I'd say for academic purposes, I probably use Twitter most often. And I think that people should look out for, there's 2 sets of guidelines that I've worked on that are coming out. So one is Canada's coming out with new 24-hour movement guidelines. So this is to replace Canada's physical activity guidelines, and it'll incorporate guidelines for sleep, sedentary behavior, and physical activity. So that's coming out in October through CSEP and the Public Health Agency of Canada. And then Osteoporosis Canada is coming out with new guidelines. The planned release was November. We'll see. I'm not sure if that's still the intention, but yeah, so those guidelines will come out as well. And I'm really excited about that. And then hopefully we'll have, happy to chat with you maybe in a year or two once our vertebral fracture project is done, because I think that'll be really interesting. Yeah.
That is fantastic. Thank you so much.
Yes, no problem. Take care, guys.